Thank you for this opportunity, Ed, to speak to a group of individuals of clinicians who are respiratory therapists, who are nurses, and who are physicians. What I'm going to speak about with you today deals with the first hour when the baby is born. And I'm going to start from the point in the delivery room. And there's some things that I want to bring to your attention that I think that you should remember. Some of you may already be aware of it. It may be nothing that's new to you. Some of it may be new to some individuals. So it's something that I want to share with you today and help you, hopefully, help the transition of that baby from when they come out of mom's uterus to the NICU. Okay. Just a couple things in terms of fetal transition to extrauterine life. Once that baby is born, there's a couple of things that happen that will allow that baby to have that first initial breath. One is if it's a vaginal delivery, it's that thoracic squeeze. 1/3 of the fluid is squeezed out, another 2/3 is absorbed. Right? Now, hopefully, everything will occur without any problems. But sometimes with a premature baby, that's not the case. Right? With the initiation of the first breath, we know it takes place by asphyxia, one of the situations, recoil of the thorax, as well as the environmental changes. Just coming from an environment where it was nice and warm, where it was comfortable, coming outside to an environment where it may be slightly cold, right, where there may be more light and more noise. One thing for you to remember, and I'm sure you already know, is this, that when they come out into the environment, the new environment, you have to make sure that environment is a warm environment, because we know that for the premature baby, cold stress is one thing that can affect that transition. One thing that is important in that transition is a transition from fetal circulation to adult circulation. In fetal circulation, you know you have 3 shunts. You have the ductus venosus, you have the ductus arteriosus, and you have the foramen ovale. And if one of those shunts do not close correctly, then you can have problems with oxygenation with that particular baby. And the steps that you have to take when you're in the delivery room, as well as when that baby comes to the neonatal intensive care unit, that will ensure that those shunts hopefully will stay closed and minimize any sort of shunting that would take place. Right? There's things like acidosis, for example, things like cold stress that could possibly prevent these shunts from closing. And the actions that you take in the delivery room, the actions that you take in your neonatal intensive care unit can actually affect whether or not these shunts will close. In terms of why would a premature infant have some difficulty with this particular transition, for the neonatal population, for premature babies, their chest wall is not very compliant. It's very stiff, right? So there's more prone for atelectasis to occur. Right? And they also lack an adequate amount of surfactant. And you all are aware that when you lack surfactant, you may have those alveoli that initially will open up, right, on that particular first breath. And it all depends on how much peak inspiratory pressure you're using, how much PEEP that you're using. Because you may use an adequate amount of pressure to open up that alveoli, but maybe you don't have enough PEEP to keep it open. Right? So the next breath, when you go to deliver for that particular baby, it's sort of pulling that alveoli apart, especially if you lack an adequate amount of surfactant. Right? So that could affect that transition for that particular premature baby. As well as for the premature baby, the difficulty in removing some of that fetal lung fluid. In preparation for the resuscitation, how do you get prepared? There's things that have taken place over the years that have helped that transition in terms of from intrauterine life to extrauterine life for the neonatal population, as well as for the term babies. I know when I first started working in the neonatal intensive care unit, it was very easy. I mean, for me, I started back in the early 1980s, so there was only basically one mechanical ventilator that I had to be concerned about, and that was it. So it was very easy, one mode of ventilation that was very, very easy at that point in time. There was no antenatal steroids that we were concerned about, whether or not that was going to help mature the lungs for that particular baby. It did not exist when I started working in the neonatal intensive care unit. But now there are antenatal steroids that are given to the mom. And when they're given to the mom, it helps to mature the alveoli for that particular premature baby. Also, in preparation for that delivery is making sure that there's skilled personnel in the delivery room. And it's also, you would know that by anticipation of any particular risk factors, whether the interpartum or antepartum risk factors that you may be aware of. Maybe you are the nurse, maybe you are the respiratory therapist, and part of your responsibility is to go to that delivery for a high-risk delivery in your particular institution. So you need to make sure that you have the skilled individuals in that delivery room that they can handle that resuscitation as well as do the intubation for that particular baby. Also, in preparation of equipment, right? What equipment will you need for this particular delivery? Making sure that radiant warming is on, making sure that the oxygen is on, anywhere between 5 to 10 liters per minute. Right? Making sure that your laryngoscope, your ET tubes, everything is all ready for that particular resuscitation. And as well as surfactant therapy. What is going to be your philosophy for surfactant therapy? Before you walk into that delivery room, if that's part of your responsibility, what do you believe in? What is the belief of that particular unit that you work in? Is it prophylactic surfactant therapy that you're going to do? So that's what you need to be thinking about, as well as, I believe, lung protective strategy. It starts in the delivery room with lung protective strategy, and it needs to continue once you get into the neonatal intensive care unit. In preparation for resuscitation, basically all infants require approximately 10% of the infants or more, resuscitation of newborn infants occurs approximately 10% of more than 100 million infants born annually worldwide. Doing resuscitation may revive many infants, but we may cause harm in that resuscitation process. When I say harm, maybe if you're not aware of the lung protective strategies, maybe you may use too high peak and story pressures, maybe you're not using enough PEEP, for example. From the first breath of preterm infants, they must be helped. We must help them in terms of removing the fetal lung fluid, recruiting the alveoli and keeping them open, helping to maintain the FRC for that particular baby, protecting the lungs. And this is where the lung protective strategy comes in. Protecting the lungs and making sure that we're using the right amount of pressure with the lowest possible volume for that particular baby. And whether or not we're going to use any surfactant therapy. Some of the things I just want to talk about with lung protective strategy, we have talked about a lot in the adult population in terms of volume trauma, electromic trauma, as well as biotrauma. When we're talking about these things, we're talking about how much pressure are we going to use, and how much pressure we're going to use, which means how much volume. If you're using pressure, that volume is going to depend on your compliance and your airway resistance. So your volume is going to vary from breath to breath. So you may be using the same consistent pressure, but the volume is going to vary. How do you minimize the presence of atelectasis? And we're going to talk about it in a few minutes, as well as avoiding high FiO2s that can add to oxidative stress. When it comes to volume trauma, you need to remember about overdistension, making sure that you're not using too much volume for that particular patient. And we typically think about using between 4 to 7 mLs per kilogram in the neonatal population. But if you go back, if you think about in the adult populations, there have been studies about how much volume do you use. And they've come down to using small volumes in the adult population. And there are some research in regards to the neonatal population and the term babies, but not a lot in terms of how much volume do we really use for this patient population. So that initial peak pressure that you need to use for the premature infants and the term infants, you need to make sure that you're using that right initial pressure, and you're really not going to be certain what that initial pressure is going to be. They're recommending roughly that initial first breath for the term baby could be as much as 30 centimeters of water. And for the preterm baby, it's roughly between 20 to 25 centimeters of water. I'm not saying that every single breath that you deliver in that delivery room should be at 30 centimeters of water for that term baby. I'm not saying that every breath that you deliver for that preterm baby should be between 20 and 25. But I'm saying that initial first couple of breaths may require that high pressure in order to open up the alveoli. The key is now once you have that alveoli open, how are you going to keep it open? And it deals with having the right amount of PEEP to keep that alveoli open. And that's the one thing that you have to remember. You may have done the correct steps with the initial couple of breaths with the right pressure, and now you need to determine how much PEEP you're going to use. Alrighty? And according to the International Alliance of Committee on Resuscitation and NRP, alrighty, they basically recommend the use of CPAP and PEEP to basically reflect what's happening in your particular institution. Alrighty? So you know that you're going to need to start with 4 to 5 centimeters of water, but is that really going to be enough? Do you need more? Do you need less? And what they're recommending is that you determine in your institution what should be good to keep those alveoli open. In terms of ventilation and biotrauma, biotrauma deals with your FiO2. And I remember in doing resuscitation in the neonatal intensive care unit when I was working clinically, that the first thing that you would do almost immediately was that you up the FiO2 to 100%. That was just, you just did that. And now what they're finding more and more of that is that oxidative stress that occurs in the neonatal population. So now the recommendation in regards to NRP is that with a term baby that you could start out with resuscitation, starting out with room air, and then up it based on the saturation on that particular baby. But what they're also saying that it may take up to 10 minutes to get to that saturation range between 85 to 95%. Now this is for the term baby. In terms of research for the preterm babies, what they're recommending is at this point in time that you definitely start out, just like with the term with the blender, right? And you're going to adjust your FiO2 based on your saturations. And you need to put a pulse oximeter on for preductal saturations. So this is a change. In the 5th edition of NRP, they spoke about the use of room air versus 100%. And now in the 6th edition, once again, they're just recommending that with term babies, you can start out with room air and go to 100% if you need to. And with the preterm babies, that you're definitely going to use the blender. And you may have to start with about 30%, but definitely adjust it based on your pulse oximeter. Okay. When it comes to surfactant therapy, okay, what are you going to use? Right? Is it going to be prophylactic therapy? Is it going to be rescue therapy? Now, when it comes to prophylactic therapy, you are assuming that that baby who's born prematurely is going to have RDS. And if that baby's going to have RDS, then you're going to intubate the baby, you're going to deliver surfactant, and then you're going to extubate the baby. And that could be the belief of your particular institution. Right? Or at your institution, the belief could be that, you know what, we need to confirm that this baby does have RDS, and you're going to consider delivering surfactant as rescue therapy. So confirmation comes once the baby has arrived to the neonatal intensive care unit. Once that chest x-ray, it could be based on the clinical presentation as well. So it all depends on what your belief is. And what I'm going over now, I just sort of believe that before you walk into the delivery room, you need to know what you're going to do. What is your belief? How are you going to manage that particular baby? You need to think about that lung protective strategy. You need to think about, what are we going to do here? What type of surfactant therapy do we do in our particular institution? When it comes to surfactant therapy, clinical preference will determine, once again, whether or not you're going to use prophylactic or whether or not you're going to do rescue surfactant therapy. But there's some information that, in terms of the use of prophylactic therapy, comes from the studies that were basically in the 1980s and early 1990s. And that was really before the antenatal steroids that were given to the moms to help mature the lungs. Right? Now with the widespread use of the antenatal steroids at this point in time, clinicians are starting to question, do we really need to do that prophylactic therapy? Should we wait until that baby has arrived into the neonatal intensive care unit and we have determined that the baby does have RDS? So what's happening now, and also with the newer modes of mechanical ventilation, we started out with INV. Now we have, SINV or assist control. We have volume targeted ventilation. So you have new modes of ventilation as well as the steroids. So clinicians are now saying, well, wait a second, maybe I don't need to give this surfactant therapy in the delivery room. Maybe I need to wait. So you need to be thinking about this or looking to this and determine what you are going to do in your institution. So you did the initial steps of that initial thinking process of lung protective strategy, of whether or not I'm going to give surfactant or not give surfactant, thinking about the right pressures am I going to start out with? What will be the initial pressures? What type of PEEP am I going to use? So that's what you're going to have as you walk into that into that delivery room. You're going to have that already going through your mind, so you know what steps you would take in the actual delivery process. Now you walk in with those thoughts in your mind. Now you have to get ready for that particular delivery. You've gotten a call that there's a baby in the delivery room, that there's meconium in the amniotic fluid. So you go over to the delivery room for preparation for that particular delivery. How are you going to prepare? You're going to prepare by turning on that radiant woman. You're going to prepare by getting out your resuscitator bag, whatever device you use, whether it's a resuscitator bag or T-piece resuscitator. Right, for that particular institution. You need to make sure that you have out your equipment like laryngoscopes, your blades, your suction equipment, making sure the suction is set up to the proper pressure. With the radiant warmer, making sure that it is on, righty? And also your linens, making sure that your linens are pre-warmed, as well as medication. Right? So these are things that you're going to need once you get into the delivery room for the actual resuscitation for that particular baby. In terms of equipment, what size endotracheal tube am I going to need? What is the gestational age of that baby? You're not going to know the weight before the baby is delivered, but you know the gestational age. So getting out the proper endotracheal tube, getting out the proper blade size. If you're going to use a stylet, getting out the stylet as well. Checking your equipment. Is my equipment functioning correctly? Do I have the correct size mask for that particular baby? And selecting my mask, do I make sure the mask, is it in the eyes? No, I don't want it in the eyes. I need it to cover the nose as well as the mouth to make sure that I have an adequate seal. My resuscitator bag, do I use a self-inflating bag for my particular institution? Do I use a flow inflating bag? Or am I going to use a T-piece resuscitator? Once again, you will know this before you go into the delivery room. But once you get there, you need to check out your equipment to make sure that it's functioning correctly. Okay? And this is all in preparation for the delivery. Whatever you decide to use, make sure that it is connected to oxygen. Make sure that your flow is on. They're now recommending between 5 to 10 liters per minute for your resuscitator bag. And making sure that you check out your device, whether it's a resuscitator bag, whether it's a T-piece resuscitator bag, to make sure that it is functioning correctly before the delivery of that particular baby. And what else do you have to consider before that baby comes out? You already did the initial thought process of, in my lung protective strategy, my proper PIP, my proper PEEP, and we're going to use, making sure I use the right amount of FiO2 following my pulse oximeter or preductal saturations. I've already checked for my equipment for that particular baby. Now, what else do I need to consider? Am I going to use CPAP? How much PEEP am I going to use? Ready? Am I going to do intubation, extubation? Am I going to deliver surfactant in that process? Am I going to do sustained inflations? Right? Am I just going to go ahead and intubate that baby if it's needed for that particular baby? And what will be my process for a baby who's meconium stained? Let's talk a little bit about sustained inflations. When it comes to sustained inflations, the thought process that some institutions will utilize is for that first initial breath for that particular baby, they're going to give PIPs. And the PIPs can be anywhere, right, between 15 to about 20, even a little bit higher in terms of the initial PIP that you give to that particular baby. Right? Sometimes institutions will go up as high as 30 centimeters of water for that initial breath. And with sustained inflations, they may hold it there for roughly about 10 to 15 seconds. Now, with the resuscitator bag, it's sometimes difficult to hold that pressure for 10 to 15 seconds. They have found that basically you can do it in roughly 2 to 5 seconds, but longer than 2 to 5 seconds is difficult to do. So you're going to be doing it probably with like a T-piece resuscitator and keeping those sustained inflations there for that particular baby. And the thought process behind that is now you're able to maybe open up some of the alveoli for that particular baby using those high pressures. But more importantly, once you get them open, you have to keep them open. And how are you going to keep them open? You're going to keep them open with the proper PEEP. Right? So with the sustained inflations, what the International Liaison Committee on Resuscitation and NRP, they suggests that that initial inflation pressure that you're going to use, and then how long you're going to use it, once again, will be based on clinical preference. But that's something that you need to think about before you walk into the delivery room. Will I be doing sustained inflation for that particular baby? Now the baby is delivered. What am I going to do next? If there's no meconium, once the baby is delivered, the baby goes over to the radiant warmer. You're going to provide the warmth for that particular baby. Righty? You're going to position the baby's head. You're going to clear out the airway, suction out the nose, and suction out the mouth and then the nose, excuse me. You're going to dry the baby and then remove the wet linen. Righty? Now at this point in time, it's evaluation for that particular baby. And you're going to evaluate whether or not the baby's breathing. You're going to evaluate the heart rate, and you're going to evaluate the color. Now, with the new 6th edition of NRP, in terms of evaluation of color, what we used to do, what everyone used to do, I should say, you were looking at the baby. You were looking to see whether or not that baby was cyanotic. You were looking at the baby whether or not there was acrocyanosis. You were looking at the baby to see whether or not the baby was pink. Right? Now, they want you to use a pulse oximeter, and some people may have already been using the pulse oximeter in the delivery room, but they're definitely requiring that the pulse oximeter should be available for use in the delivery room, and you need to place the pulse oximeter probe on the preductal for the baby. If there's no meconium at this point in time, and you've done the initial steps of providing warmth, of suctioning out the mouth and nose, of positioning the head, removing the wet linen for that particular baby, right? At this point in time, that's when some clinicians may do the CPAP and the PEEP. That's when they may do the sustained inflations for that particular baby, right? Once again, you should have thought about this before you came into the delivery room on what type of practice you were going to use. You've decided to go forward, and you're not going to use any PEEP or CPAP. You're not going to do sustained inflation. So you go, after you do the initial steps of resuscitation, it's the evaluation and respiration is the first part. Is my baby breathing, or is my baby not breathing? If my baby's not breathing, then it's providing a little tactile stimulation and see if you get any particular response. There are some clinicians that feel that after that initial phase of drying the baby, and suction out the mouth and nose, that should be enough stimulation for that baby, and the baby should be breathing. And if they're not breathing at this point in time, they may go straight to some sort of positive pressure ventilation. But you're assessing to see, is the baby gasping at this point in time? Is it labored breathing or unlabored breathing that's taking place? And we all know that the success to resuscitation is adequate ventilation. So you don't want to jump past this step of ventilation. You want to make sure that you are doing effective ventilation for that particular baby before you move on. You have 30 seconds to go through the process of evaluating the baby. You're going to move on to the heart rate. What is the heart rate for this particular baby? Is my heart rate above 100? Is the heart rate less than 100? Is the heart rate less than 60 beats per minute? So what's going on with this particular baby? What is my heart rate? And you're going to check your heart rate by listening with a stethoscope or by touching at the base of the umbilical cord for checking for a pulse. Right? You're going to count for 6 seconds and then multiply by 10, and that will give you your heart rate. And from there, it will determine what actions you're going to take. Okay? And what does my baby look like? Hopefully by this point in time, you have a pulse oximeter there, and you have placed the pulse oximeter on this particular baby. When you're checking for your saturations, like I mentioned before, it could take up to 10 minutes to get a saturation between 85 to 95%. And the new NRP guidelines, right, they give intervals between 1 to 10 minutes of what saturation range that you should be looking for a term baby. Room air versus 100%. What are you going to do for this particular baby? Right? In terms of term babies receiving resuscitation at birth, you're going to begin positive pressure ventilation. You're going to begin positive pressure ventilation with air rather than 100%. Right? So with term babies, this is the new recommendations that they have for term babies. If despite effective ventilation there's no increase in heart rate or oxygenation, you're going to be guided by your pulse oximeter, not by the color of this particular baby. Now, with preterm babies less than 32 weeks of gestational age, They are recommending that you use a blender and that you're going to adjust your FiO2 based on the saturations for this particular baby. If there's meconium in the amniotic fluid and you have prepared for this particular delivery for a meconium baby, your steps are going to be slightly different once that baby is born. The first example that I gave you was for a baby that had no meconium in the amniotic fluid. This is for a baby who has meconium in the amniotic fluid. Right? Roughly about 10 to 20% of all births will have meconium in the amniotic fluid, but only about 4 to 10% of these babies will actually have meconium aspiration. Right? And the steps that you take, the initial steps that you take in preparation, will hopefully minimize the meconium aspiration for that particular baby. Right? Now, with meconium, it can happen either in utero or postnatally. Now, with meconium, the one thing that, just to be reminded, there could be partial blockage, there could be total obstruction, and there's also the chemical pneumonitis because you have a foreign substance that is going down to the airway. So when it comes to a partial obstruction for that particular baby, the meconium will get in the airway, and as you go to ventilate the baby, the air goes in, but it does not come back out again. Right? So that alveoli continues to expand. So now you run the risk of a pneumothorax. With the chemical pneumonitis, your concern will be the inflammation in the airways for that particular baby. So the steps that you take in the resuscitation room could possibly minimize how much meconium that baby would aspirate. Once the baby is born, you need to determine whether or not the baby is vigorous or not vigorous. Right? And there's a couple of things that you need to look at. You need to look at the respiratory effort for this particular baby. You need to look at the muscle tone. And you need to check the heart rate. Is the heart rate greater than 100? Right? If the baby is born that is meconium stained, and you find the baby has a good, strong respiratory effort, the muscle tone is good, and the heart rate is above 100, then you're going to go ahead and continue with the initial steps of resuscitation. If the baby is born and the meconium and the baby is not vigorous at this point in time, that means there's poor muscle tone, the heart rate is less than 100, and it's poor respiratory effort. Now, the steps that you're going to take at this point in time will be different. You don't want to do any stimulation to that particular baby because stimulation could cause that baby to aspirate the meconium. So once you get the baby and you go over to the radiant warmer at this point in time, you're not going to dry the baby, right? Because that will cause stimulation, that will cause potential aspiration of the meconium. Right? So at this point in time, you're going to go ahead and consider alrighty, intubation for this particular baby in order to clear the airway. You don't want to do blind suctioning of the airway because blind suctioning could actually cause that meconium to be aspirated. So when I say suctioning, what you should think about, what you need to do, is actually put the laryngoscope in the airway. As you visualize in the airway, if you see any meconium in the airway, you're going to suction at that point in time. You'll be prepared to do the intubation with your endotracheal tube. You'll intubate. On the end of the endotracheal tube will be the meconium aspirator. At this point in time, you apply suction and you remove the endotracheal tube. So your steps will be different if it's a meconium baby and that's not vigorous. Going back to our initial baby where there's no meconium in the amniotic fluid, if that baby was not breathing and you have provided some tactile stimulation and the baby is still not breathing, at this point in time, you would go ahead and do some positive pressure ventilation at a rate of 40 to 60 breaths per minute for this particular baby. And you're going to assess that baby to see if there's any improvement. When you're doing the positive pressure ventilation, once again, you may need initial pressures of anywhere between 30 centimeters of water or up to 20 to 25 for a preterm baby. That means that the resuscitator device that you're using should have a manometer on it so you know what pressures that you're delivering to that particular baby. You're going to be checking again for the breathing. 30 seconds after doing positive pressure ventilation, you're going to once again check for the breathing and see how the baby is doing. Alrighty? If the baby remains apneic or if the heart remains less than 100, you need to go ahead and continue with your positive pressure ventilation for that particular baby and also consider doing intubation. How do you know your baby is improving from doing that positive pressure ventilation? Right? When you're doing the positive pressure ventilation and you're going to assess for adequate ventilation, you're going to look at the baby for improvement in heart rate. Right? You're looking for improvement in color and improvement in your pulse oximeter for that particular baby. And how do you know that you're doing effective ventilation at that point in time? How do you know that you're doing effective bag and mask ventilation if you're using resuscitated bag? You're looking for that bilateral chest excursion. Ready? You're looking to make sure that you hear pretty good air entry going into the lungs, but also making sure that you're not using too much pressure for that particular baby. I already mentioned that those initial pressures may be high to open up the alveoli, alrighty? But once again, you don't want to stay at too high pressures. There are some institutions when they're doing resuscitation, they also will have PEEP valve on the resuscitated bags as well, because if the philosophy is that you're trying to open up the alveoli, you need to keep them open with the PEEP. So it all depends on the institution that you're working with as you're doing the positive pressure ventilation in terms of opening the alveoli and keeping them open. Now you're going to check again for the heart rate. What is our heart rate right for this particular baby? So after doing positive pressure ventilation for 30 seconds, you're going to recheck your heart rate to see what the heart rate is for this particular baby. All right, is my heart rate greater than 100? Is my heart rate less than 100? Is my heart rate less than 60 beats for this particular baby? Ready? If my heart rate is greater than 100, then you will continue with positive pressure ventilation, assess to see whether or not the baby is breathing, and then go from there. Right? If my heart rate is less than 100, then you will continue with positive pressure ventilation for that particular baby. If the heart rate is less than 60 beats per minute, and you know that you are doing effective positive pressure ventilation, now's the time to think about doing chest compression for this particular baby. You have to do chest compressions, right? Now, with the NRP in the 5th edition, they talked about doing chest compressions for 30 seconds. Now they're saying you should do chest compressions for up to 40 to 50 seconds with positive pressure ventilation. So instead of doing 30 seconds of positive pressure ventilation and chest compressions, they're now recommending that you do 40 to 50 seconds of chest compressions and positive pressure ventilation. Okay? At this point in time, if this baby is not intubated, you need to think about intubating this particular baby, and also think about administering epinephrine for this particular baby. When you're doing chest compressions, right, you're going to be doing 30 breaths per minute. The ratio is 3 to 1, right? And you have your cadence of 1 and 2 and squeeze and breathe, 1 and 2 and squeeze and breathe. I'm still in the 1 and 2 and squeeze and breathe because that's what it was years ago, but it's 1 and 2 and 3 and breathe. But I go back and forth in terms of doing 1 and 2 and squeeze and breathe. Right? So you need to make sure that you are doing 30 breaths per minute. And when you're doing chest compressions, you can do 2 fingers or you can do 2 thumbs. When it comes to NRP, they recommend that the 2-thumb method is the more effective method for chest compressions versus the 2-finger method. Once the baby is stabilized, excuse me, once the baby is stabilized after the resuscitation methods, you're going to go over to the delivery room. Once you get there, I already spoke about the initial part in the delivery room in terms of lung protective strategy, in terms of what pressures you'll be using, in terms of PEEP that you would use for that particular baby, and making sure that the resuscitation steps are the correct steps for that particular baby. Now the baby has come over to the neonatal intensive care unit, and you need to continue with those lung protective strategy thought process for that particular baby. All right, when you're doing mechanical ventilation, you have to think about doing adequate pulmonary gas exchange for that particular baby, making sure that there's patient and ventilator synchrony that takes place for that particular baby. And that means selecting the correct mode, right? Not only selecting the correct mode, providing the adequate flow rate, what sort of inspiratory trigger you're going to use for this particular baby, right? How's that breath going to end? And also avoiding air trapping. Minimizing any sort of lung injury in terms of barotrauma. Right? Selecting the correct respiratory rate, selecting the correct inspiratory time, and making sure you have the correct peak inspiratory pressures for that particular baby. You're looking for patient comfort for this particular baby. Okay? Time constants. Okay? If you're not thinking about time constants, you need to think about time constants when you're doing mechanical ventilation. And how are you going to recruit those alveoli, and how are you going to keep them open? Once again, the target tidal volume range that's often talked about is between 4 to 7 mLs per kilogram. How much PEEP are you going to use? In the adult population, we have optimal PEEP. We can find out how much PEEP is good for that particular baby, right? Sometimes when you're doing high-frequency jet ventilation, they talk about finding the optimal PEEP and doing high-frequency jet ventilation. But what is the optimal PEEP when we're doing conventional ventilation for the neonatal population? Just something to think about. And also making sure once you have found the correct settings for this particular patient, assessing what is our lung volume, looking at the chest X-ray for this particular baby. Now, are you going to do mechanical ventilation? Are you going to do CPAP? Are you going to do CPAP? Are you going to do nasal intermittent mandatory ventilation? What are you going to do with the particular baby? Are you going to do bubble CPAP? That all depends on where you work and what is your thought process. What is the thought process of the neonatologist in your particular unit? What is your belief? What is the belief of the respiratory therapist, of the nurses in that particular unit? But you need to know this, and you need to be well informed in terms of what is the best thing for you to use in your particular institution. And the hardest part with some of this is that there's studies that have been done, but there's not one particular study that advocates for one sort of mode over the other when it comes to CPAP, CPAP, bubble CPAP. It all depends on what is out that way. But there's no one particular research that says one is better than the other. When it comes to neonatal conventional ventilation, we've come a long way. Right? We've come a long way when it comes to ventilation. We started out with like the BB200 or the infant star, for example. Right? I started out with the Bourne's LS 104 when I was doing my neonatal and pediatric rotation at Yale New Haven Hospital. Right? I remember using that ventilator when I first started. Right? I remember when I first came into the neonatal intensive care unit, all we used in our unit was the BP200, and it was very simple. It was just typical IMV, and that was it. So IMV and CPAP, that was the only thing that we had to be concerned about, and that was it. And then we evolved. We evolved into SIMV, into assist control and pressure support. As respiratory therapists, you know that those modes of ventilation already existed in the adult population. So it was really getting the nurses and the neonatologists used to these new modes in this particular patient population. Right? And so we've come a long way. Now we're up to using pressure control as well as other modes of ventilation. So now you're in your unit, and what are you going to use? Am I going to use time cycle pressure limited? Am I going to do pressure control? Am I going to do volume target ventilation? Right? Do we use high frequency oscillation in our unit? Is there a certain criteria that says at this point in time we're going to put our baby in a high frequency oscillator? Are we going to do jet ventilation? Right? So what type of ventilation are you going to use? And what I want to share with you, you have to be informed in terms of what the modes are, how do you use them in the neonatal population, what settings do you start out with, what will be the best lung protective strategy for this particular patient. So these are the things that you need to think about, and you need to think about using in your particular unit. What will be best? And sometimes it's not the best mode of ventilation for every single patient. Every patient may be slightly different, but you have to make that decision. In terms of settings, and I just selected these settings to give to you for right now, and I just said time cycle pressure limited, SIMV, and pressure support, for example. Right? If you're doing time cycle pressure limited, SIMV, and pressure support, if you start out with initial PIPs of between 15 to 20, right? How do I know that 15 to 20 are good starting pressures? You're going to assess your patient for bilateral breath sounds, for bilateral chest excursion. You can look at your pressure volume loop to make sure that you don't have over-distension that's taken place. You look at your exhaled tidal volumes to make sure they're in the range of 4 to 7 mLs per kilogram for that particular baby. Okay? But once again, how do we know that this is the correct starting pressures? How much research has been done to determine that this is the correct starting peak and strike pressures for the term babies as well as the preterm babies? Okay? When it comes to PEEP, I can honestly say that when I worked in the neonatal unit, I was one of those therapists that I was stuck on 4 centimeters of water. I didn't want to move. Right? And I don't know why I was there, but I didn't want to move from that 4. Right? But now I'm thinking, okay, I give you a range of 3 to 6, but how do I know that 4 is the best starting point? How do I know that 5 is the best starting point, or 6? Like I said before, with the adult population, we have the optimal PEEP, and we can determine our best starting PEEP. And maybe this is something that needs to take place in the neonatal population, finding out what is the best starting PEEP for this patient population. A respiratory rate anywhere between 30 to 60 breaths per minute. A flow rate between 4 to 10. And when it comes between starting with the flow rate, where do you start? A lot of times when I'm teaching at school, I say to students, maybe start on the lower end of the scale, right, for the preterm babies, and go to the higher end for the term babies. But you also have to look at your scalars, look at your flow scales and see what it shows you. And you're going to have to adjust your flow rate from there. Your trigger level, where do you start? Starting at 0.2 liters per minute. And pressure support, starting between 8 to 10 in terms of your target tidal volume. But the key point in just giving you these settings, whether it's time cycle pressure limited, whether it's pressure control, whatever type of ventilation that you're using, is making sure that you're reassessing your initial starting settings. Looking at those things in terms of your PIP, looking at your chest excursion, looking at your exhale tidal volume, looking at your pressure volume loop to make sure that you have the proper initial settings for that particular baby. Now in terms of mechanical ventilation, and this is just a couple of ventilators that are out this way. There are so many ventilators that you can choose from, so many ventilators. Right? And you have to make the decision which mechanical ventilator that you're going to work with. For example, I mentioned to you before in terms of high frequency ventilation. When it comes to high frequency ventilation, is it rescue that you do? Is it proactive? Or is it early intervention that you use in your particular institution? Right? When you do high frequency oscillation, you're recruiting the alveoli to keep them open. Right? And when you recruit the alveoli to keep them open, you're looking for that proper mean air pressure for that particular baby. But once you find that mean air pressure, you have to go check your chest x-ray to make sure that you have proper lung inflation. What pathology are you working with in terms of oscillation? Are you working with RDS that you want to recruit alveoli? Are you working with the air leak syndrome that you not really want to recruit a lot of alveoli? So what exactly are you doing? So you need to make sure that you're familiar with the different pathologies for the neonatal population, and you're using the right strategy when it comes to high frequency oscillation. I have here rescue, proactive, and early intervention. Right? There's some institutions that believe once the baby is born, stabilized in the delivery room, once they get over to the unit, they're going to go on the oscillator within a certain amount of time frame. Whereas other beliefs is that once the baby is born, they're brought over to the neonatal intensive care unit, and then they're put on conventional mechanical ventilation. And if the baby is not doing well, after a certain point in time, that's when I say not doing well, the blood gases are not good. Right? You have increased your settings on your conventional mechanical ventilator, and clinically the baby's not looking well. At this point in time, that's when they switch over to the oscillator. So it all depends on what your beliefs is at this point in time. And then it's also high frequency jet ventilation. Right? And once again, every institution is different in terms of where to start in terms of high frequency jet ventilation. And I just want to, and just sort of starting to summarize here, when it comes to that golden hour, that first hour, once again, I believe it starts before you walk into the unit. Once you walk in the unit, you should be aware of lung protective strategies. When you walk into the delivery room, you need to be aware of lung protective strategies. You need to be aware of, what am I going to do? Am I going to do CPAP? Am I going to do sustained inflations for this particular baby? Or we do not believe in that, and we just go ahead with initial steps of resuscitation and follow through with positive pressure ventilation. Do I use a resuscitator bed? Do I use a T-piece resuscitator? But being aware of how much FiO2 do I use, making sure that I have the pulse oximeter placed in the correct position for that particular baby. And then once the baby is brought over to the neonatal intensive care unit, making sure that you continue along with your lung protective strategies. And most importantly, make sure that you are aware of the different modes of ventilation that are available for the neonatal population, and be willing to change. Don't stay in that one box of one particular mode of ventilation because that's your comfort zone, but be willing to come out of that box and try new modes of ventilation for that particular baby. And I thank you for your attention.